Good evening, wherever you are. Welcome to another intensivecarehotline.com live stream. We'll just give it another minute and wait for people to come in while I'm getting everything ready. Want to welcome you again to this live stream. We'll just give it another 30 seconds or so while I'm getting still prepared to get my notes ready. And then we can get started. Okay, I can see that people are slowly coming in. Again, good morning everyone, or good afternoon wherever you are, good evening. So let's start with today's presentation, which is my 35-year-old brother has had a cardiac arrest after liver failure and is now in ICU. What should I expect? And I want to talk about a real case study here, obviously with a client that we're working with at the moment, or worked with. Because this is obviously, now that COVID is sort of, touch wood, sort of slowly but surely getting, we have fewer and fewer clients with COVID, which is good. We're sort of more now broadening out again into more general intensive care cases, which pretty much disappeared for the time when COVID was running rampant. So let's look at that today. So before I go into today's topic, just some housekeeping issues. If you have any questions regarding today's topic, please type them into the chat pad and I will get to them. If you have any questions that are not related to today's topic, type them into the chat pad as well, and I will get to them at the end of today's topic. Also, I will give you the option to dial into today's show after I've gone through today's presentation. Now, before I go further into it, you might wonder what makes me qualified talking about today's topic. I am a critical care nurse by background. I have worked in intensive care for over 20 years in 3 different countries. I have worked as a nurse unit manager for over 5 years. I have been consulting and advocating for families in intensive care all over the world since 2013, so coming close to 10 years. And I'm also owning and operating a service, intensive care at home, where we basically send intensive care nurses into the home, predominantly for long-term intensive care patients in the home with intensive care nurses. So mainly for ventilation, tracheostomy. Okay. Let's get into today's topic. So, client is a 35-year-old young man who's had a cardiac arrest at home after some liver failure a few weeks ago. He is in ICU, and this is a very complex clinical case, and I thought it was a good opportunity to present the case so, families in intensive care can actually understand, what to expect. It's very complex with cardiac arrest, potentially hypoxic brain injury, we don't know yet, but also then liver failure. Very complex situation that people need to understand. So let me just read out a little bit about the history. Patient is, as I said, 35-year-old man with a history of obstructive sleep apnea, history of non-compliance, history of heavy alcohol use with evidence of cirrhosis, suspected respiratory failure due to CO2 retention, and severe obstructive sleep apnea, possibly exacerbated by acute alcohol. On admission, the patient was observed of having stopped breathing by his wife, who called the paramedics and performed CPR. He has had now a prolonged ICU course, but appears to be more stable. He's probably sustained an anoxic brain injury, has recovered brainstem reflexes though, such as overbreathing the ventilator, pupillary light reflex, corneal reflex, cough and gag reflexes. He does open his eyelids, his eyes will move, but he doesn't track or make eye contact or follow any commands. So sedation as of today has been weaned off, and he's certainly slowly but surely waking up, making it very difficult still to ascertain whether, he can come off the ventilator, whether he can obey any commands. He's been on sedation for quite a few weeks now. He's now at the point where he can hopefully have a tracheostomy next week. It also says in the neurology report, initially it says neurology after 1 week of sedation, and only been 2 days of sedation so far, says that prognosis for meaningful neurological recovery would be close to nil. The family wishes to remain aggressive treatment at this point in time, which is what the ICU is doing. It's interesting, to sort of read back through the reports that the neurology is saying that a neurological recovery would be close to nil. Well, I can already tell you that the family has been telling us that, he's opening his eyes, he's tracking with his eyes. So, by saying that neurological recovery would be close to nil, it's just, we don't know. We really don't know, and many patients do recover after an insult to the brain, and it just often takes time. And it's only been a couple of weeks, so it's way too early to see where this is going. Okay, next. Acute respiratory failure. The patient went into ARDS probably due to aspiration pneumonia, was seen by the pulmonologist, underwent ventilator support, which he's still having at the moment. Currently he's in a controlled mandatory ventilation mode with a rate of 10, pressure control of 8, PEEP of 8. FiO2 is around 30% of oxygen, and his tidal volumes are pretty good, around 800. His arterial blood gases are pretty good, with a PO2 of around 100 and a CO2 around 30 with a normal pH. So he's right on track there. Just needs to wake up a little bit more, and then hopefully can be weaned off the ventilator, but might need the tracheostomy. Next, saturation is in the high 70s. He does overbreathe. He does take more breaths from the ventilator than he's actually getting, which is a good sign. Current volume is around 800 mils, which is pretty good. Steroids were added because of persistent difficulty oxygenating. He did seem to respond to steroids with improvements in his oxygenation and decrease in FiO2 requirement. Discussions have taken place with the family regarding tracheostomy and Pec Tube placement, and they wish to wait to see if there's any further neurological recovery before making up their minds with this regard, but they do not withdraw life support, and I suspect that will decide on tracheostomy and Pec Tube to give them more time to monitor for a neurological recovery. And again, tracheostomy is probably due coming soon. Now, the client also had an acute kidney injury, and he has been on dialysis on and off over the last few days. He obviously does have cirrhosis of the liver, and the hospital is monitoring LFTs very closely. And again, it looks like there is some improvement there. Now, that sort of sets a little bit of the scene. And what happened next then wasn't overly surprising, but certainly made things fairly complex. And what happened next was the client was started on heparin because he had some portal vein thrombosis around his liver. And obviously then heparin was started, and to potentially dissolve those the thrombus around the liver, because that certainly doesn't help with liver cirrhosis. So after he was started on heparin, a couple of days later, he started to excessively bleed from unknown sources. But he started having melena. Melena is black stool, and melena is a sign of, generally speaking, an upper GI bleed. Generally speaking, there is a bleed in the stomach or in the upper intestines. So client ended up with an endoscopy or gastroscopy, ended up with a colonoscopy, but a source of bleeding couldn't be found. Heparin was stopped. They did find some ulcers in the stomach and in the around his upper GI. and they started him on a pantoprazole infusion at the time. His hemoglobin dropped very, very low. So hemoglobin is the number of red blood cells in the body. His platelet count was low as well. His INR and his APTD seemed to be normal despite the heparin and despite the bleeding. And then he had multiple blood transfusions at the time. He was bleeding for quite a few days, with sort of the trend was certainly moving towards that it was getting less and less, and eventually it stopped after the heparin was stopped, but he still needed blood transfusions for quite a few days. Next, he then was also started on lactulose. So why was he started on lactulose? With the liver failure, he had a high ammonium build up, right? And what that means is the liver can't metabolize the ammonium that our body produces. And if ammonium can't be metabolized, it means that the brain is becoming foggy. And with an anoxic brain injury plus the ammonium buildup, he obviously needed to be started on lactulose. Now, with the lactulose is an aperient, and he then started to have diarrhea, and and again he also had the melena, and that's not a good position to be in, having diarrhea after cardiac arrest, having liver failure. Certainly the situation became more and more complex. Anyway, so what happened next from there is he also spiked amylase and lipase parameters, which suggested pancreatitis, but that sort of was only thankfully short-lived. Thankfully, that was only short-lived, and there seems to be no indication for any further pancreatitis. He's got enough issues to deal with, Then he also ended up with atelectasis and in the lungs and a pneumonia picture that led him to become septic. And then he ended up on multiple forms of life support. So what that means is he ended up on obviously mechanical ventilation. He ended up on vasopressors and inotropes such as high doses of levofed and vasopressin, and also midodrine then eventually. And then he ended up on hemodialysis again. Very complex clinical situation and multiple forms of life support, which, one could argue he was in multiple organ failure for a period of time. And that's certainly always fairly risky. But thankfully, the infection got under control with antibiotics. His white cell count, even though in the beginning was in the 50s, has now more than halved. So it's down to 23, which is great. So they're all good signs that this young man can turn the corner, or and is on his way slowly, very slowly, to recovery. The other thing that we suggested along the lines is to do a hematology consult, especially since a source of bleeding couldn't be found. They've done, as I said, they've done the gastroscopy, they've done the colonoscopy, they've done a head-to-toe CT scan, and yet a cause of bleeding couldn't be found. The only thing that could be found was some ulcers in the stomach and in the upper GI tract. Now, from experience, stomach ulcers or ulcers in the upper GI tract can cause bleeding, right? So to give you a little bit of background here, some research has been done over the years, over the decades now of intensive care treatment, that when patients go into intensive care, it's a super stressful event. And we know that if people are not in intensive care, they might get some stomach ulcers by being stressed. Well, it's not a surprise that when people go into ICU, that they develop stomach ulcers, and then that's a risk for bleeding, right? and then you've got the heparin on top. He was on a heparin infusion. Heparin is a blood thinner, and if patients are getting started on heparin, that's a massive risk for bleeding. And also when patients have liver failure, there's also a risk that their coagulation is going off, because most coagulation factors are produced in the liver. So if patients go into liver failure, the risk for them to bleed anyway is pretty high. Now in this situation, it's almost like a contradicting situation, in terms of you have someone in liver failure where often coagulation goes off and people have thin blood anyway, and then he's developed a thrombosis in the portal vein around the liver, and he's also now developed a deep vein thrombosis in his left arm. So it's a very tricky situation where you had to stop heparin because he was bleeding, and on the other hand he was developing thrombosis either in his arm or around the liver. Very tricky situation. Under normal circumstances, you would have had to continue the heparin to dissolve those thrombosis, but in this situation it had to be stopped, which then led us to suggest to the family to ask the ICU to get a hematology consult, and we were also getting suspicious on whether this man would have thrombocytopenia, which is again a blood clotting disorder. So it turns out that when the family looked through all the medical records, and we looked through medical records, that there was a history of thrombocytopenia, but the ICU had not picked up on it to begin with. Now, would this have made any difference if they had picked up on it? Probably not. It sounds to me like, there were so many competing things going on in his body, i.e. you needed the heparin on the one hand to manage thrombosis, on the other hand you had the bleeding going on. So, how would you have managed this differently if people had known about thrombocytopenia? Probably not much different. But just to highlight that the devil in ICU is 100% in the detail, and you have to break down things into minor details. We taught the family about what else to look for, especially with bleeding. Again, they started with a gastroscopy, they did a colonoscopy, did a CT scan from head to toe. He had multiple blood transfusions over a few days to keep the hemoglobin above a level of 7. Usually the trigger point for blood transfusions in ICU is hemoglobin less than 7. We educated the family that APTT is something that needs to be watched, prothrombin time is something that needs to be watched, and INR is something that needs to be watched. Again, they are blood results, pathology results, and they relate to blood coagulation. And if those parameters are off, the risk for bleeding is even higher, right? So thankfully now we are probably a week down the track. Bleeding has thankfully subsided. No more blood transfusions were necessary. By the same token, the hemoglobin remains low because it requires, or it takes quite a few days to for hemoglobin, or sometimes weeks, to recover and go back to normal levels. Now, what's a normal level for a healthy 35-year-old man? Healthy level should be about 13 or 14, so it's far away from that, but again, it's still better than it was a few days ago. Now, hemoglobin is also important when it comes to weaning off the ventilator. Why is it important? So at the moment, this man is on 30% of oxygen on the ventilator. Room air is 21%. The air that you and I are breathing is 21%. He is currently, he's on 40% of oxygen. So that's double the amount of oxygen compared to what we are breathing in the air. Now, the more hemoglobin there is in the body, the more oxygen can actually bind to go around in the body. So therefore, the more hemoglobin is available, the quicker someone can be weaned off the ventilator, or at least the more oxygen can bind to the hemoglobin and can be transported around the body to major organs. Okay, so that's why hemoglobin levels are rather important. Other things that need to be watched when it comes to bleeding are things like platelet levels, right? Especially when it comes to diseases such as thrombocytopenia, which is which often goes hand in hand with low platelets. But platelets have actually been okay, even though he has been diagnosed with thrombocytopenia. So no platelet transfusions have been required throughout his ICU stay so far. Okay, so then what happened next was, he stopped the bleeding, and now he's been restarted on low doses of heparin because, again, he developed a deep vein thrombosis, a thrombosis in his left arm. He still got the thrombosis in the portal vein around his liver, which, again, how do you manage that? If there's a thrombosis around the liver, maybe the liver can't work properly, and might be one of the reasons why the liver enzymes are still elevated, but it's probably also a result of the man sort of drinking a lot of alcohol before his ICU admission. So what is next for this man? So one thing that the ICU team is now recommending as a next step is simply to do a tracheostomy, as he will have difficulties on coming off the ventilator, so they think. Now, in recent days, since sedation was stopped, he's certainly slowly making progress on the ventilator. For example, a few days ago, he was on 40% of FiO2, 40% of oxygen. He was on a pressure control of 10, on a PEEP of 12. That's fairly high support. On a respiratory rate of 18, meaning he was getting 18 mandatory breaths by the machine every minute. And everything was controlled. So now he's down to a rate of 10 mandatory breaths per minute, and he can breathe on top of that. He can take extra breaths, which is what he's doing, and he's down to a PEEP of 8 and to pressure control of 8. So at least now he's on numbers where they can proceed to a tracheostomy. Now the question to me, though, is, does he really need a tracheostomy? Or is there a chance that the tracheostomy could be avoided? Hard to say. He hasn't really woken up yet. It is yet to determine how severe his brain damage is, and that often doesn't show over days. It often shows over weeks, sometimes even over months. The good news is he's hemodynamically stable. His heart seems to be coping with whatever is going on. He's off inotropes, he's off vasopressors, so that's good. He's off dialysis, which is really good. His kidneys are producing urine, even though that is on some furosemide or Lasix, which is a diuretic, which increases urine output. By the same token, urea and creatinine are going up, which means the kidneys are definitely not out of the wood yet. And if urea and creatinine keeps going up, they may need to start dialysis again over the next few days. So if he was to go for a tracheostomy in the next few days, again, here is a risk. The risk is he's on heparin. They would need to start the heparin prior to the tracheostomy because the risk for bleeding during surgery is very high if someone is on heparin. So they would have to stop the heparin before he can go for a tracheostomy. That again increases the risk of him developing another thrombosis or embolus. Again, that is really a big risk. With the kidneys going off in the last few days, initially his potassium was very high. One of the first signs for kidneys to go off is that potassium is going up. Potassium levels should be between 3.5 and 4.5. If potassium levels are either too high or too low, there is the risk for cardiac arrhythmias or heart arrhythmias, with the risk of cardiac arrest. Given that this man had a cardiac arrest just in the last couple of weeks, it's really important that potassium but also magnesium levels are kept a very close eye, which is what they're doing at the moment. But potassium has been trending downwards despite some kidney failure, but that is because the the Lasix or the furosemide is working, and by him having a big diuresis, he is dropping his potassium, and they need to give him potassium. Now, here is something else as well that I think is really important for you to understand and for you to know. Again, the ICU team in the beginning was very negative about this man's outlook, and the family was adamant that, they want everything to be done. He's got a young family, he's got 3 young kids, and the hospital wanted to get palliative care involved. And they did get palliative care involved, but the family also told the palliative care team and the ICU team that, again, palliative care is not an option at this stage. And even though he was incredibly sick over the last week, where it was touch and go, multiple inotropes, multiple organ failure, hemoglobin drop, septic shock, white cell count through the roof, bleeding from unknown sources, but bleeding heavily. He now seems to have turned the corner. Sedation is off, inotropes and vasopressors are off, liver function is slowly improving, no pancreatitis, no gallstones as far as we can see, slowly making progress on the ventilator, slowly waking up. And, maybe if he does wake up, maybe there's even a chance to avoid the tracheostomy, but only time will tell us that. And I would say that, if by Tuesday he's not waking up, he might need a tracheostomy. Now, the ICU is also trying to push for a Pec tube, but again, as you may know, we strongly advise against Pec tubes, generally speaking, especially for our clients in the US, and this is actually a client in the US. And why do we advise against Pec tubes, especially in the US? Well, there's a very good chance that this man, if he does end up with a trach and a Pec tube, that he may end up in LTAC or subacute. And he's so vulnerable that, we would strongly advise against LTAC or subacute, and simply because, the level of care would be dropping significantly. This man is very, very vulnerable. And also keep in mind, he has so many issues. He needs specialist input, which he won't get in an LTAC or in subacute. He needs specialist input from a hematologist. He needs specialist input from a cardiologist. He needs specialist input from a nephrologist. He needs specialist input from a neurologist. We're just starting here to slowly turn the corner, but all these specialists need to give input. Because as you can see, multiple organs are involved, starting from the brain, heart, lungs, liver, and kidneys. All major organs are affected by this process, and many ICUs, they just want to do a trach and a Pec and then ship patients out to LTAC. It's just unbelievable. So we've already advised the family what to do to avoid LTAC, once he has a trach. And it's also unfortunate the ICU there is not telling the family about LTAC before they give consent to a trach, which is really concerning, because it's almost like bait and switch tactics. ICUs are really good at, quote unquote, selling the families on a trach. And whilst it's clinically appropriate and clinically probably necessary in this particular point, in this particular case, it is not appropriate then to do the trach and then a day later tell the family, oh, now he's got the trach, now he needs to go to LTAC. But again, like I said in many other videos, again, this is probably very specific to our US audience, do not consent to a Pec tube. Your loved one will be perfectly fine with a nasogastric tube for nutrition, assuming your loved one is not pulling out the tube. If they keep pulling out the tube, that's definitely concerning. But this gentleman so far has not been pulling out the tube, so I'd just say keep going, because LTACs will not take patients without a Pec tube. So by not giving consent to a Pec tube, it almost puts a stop to the ICU sending your loved one anywhere. Now, I will say this, expect some resistance from the ICUs when you don't give consent to a Pec tube, but that would be for another conversation. Next, obviously with all the bleeding going on last week, they also stopped the feeds because he was bleeding somewhere around the stomach, upper GI, upper gastrointestinal tract. So by him bleeding and not having feeds, the question inevitably was raised, what about nutrition? This is a big man. He can't just be starved there. So once they had stopped the nutrition for a couple of days, they then restarted with what's called trickle feeds. So what that means is, they start then on 10 or 20 mils an hour, making sure he's getting some nutrition, and then as hopefully he's absorbing feeds, they can increase the rate of feeds. What's also important in a situation like that is, because this man is in kidney failure, to give some feeds that are not upsetting the kidneys, right? There are special feeds that can be given that are specifically designed not to upset the kidneys. So as you can see, the devil is in the detail for any patient in ICU, but there are so many things to be considered that, you need help to break things down for you, and you need to be able to ask all the right questions and interpret all the numbers. For this particular client, we are reviewing the medical records daily and advise the family, what to look for, what questions to ask, what's important. For example, the family wouldn't have had an idea that in a situation like that, he needs cardiology input, he needs hematology input, he needs nephrology input, he needs gastroenterology input. So we've asked the family to get all that input from the specialists, and they obviously communicated that to the ICU team, and they got all the specialists involved. But the question is, would they have gotten all the specialists involved if we hadn't advocated for it? Again, the devil is in the detail. Now, what do I expect going forward? I tell you what I expect pretty much for any complex patient in ICU. I do expect 2 steps forward, 1 step back. So what do I mean by that? He's just coming out now of a septic picture. He's just turning the corner from the infection. But I do expect, some setbacks, whether that's potentially more bleeding, whether that is potentially another, chest infection / pneumonia. Maybe he needs some more inotropes down the line. The risk for an hospital-acquired infection is pretty high as long as he stays in hospital. They also need to manage the fluid balance very closely. For example, I've seen that in the last 24 hours, he's been 4.5 liters negative, which also means he would have been fluid balance positive over a few days, probably from all the blood transfusions. But now they need to manage the fluid balance. And why is this important? Anyone on a ventilator, you want to keep dry, for lack of a better term. Why do you want to keep them dry? You want to have a negative fluid balance. The worst thing that can happen is you have fluid overload in the lungs, and then it'll be very difficult to get off the ventilator. On top of that, this man has kidney failure. Again, you want to keep someone dry with kidney failure so they're not getting fluid overloaded. One of the first organs that fluids are accumulating is in the lungs, and that would make things difficult to get off the ventilator. So just quickly coming back, I mentioned earlier the ammonium levels were high. Again, he's been started on lactulose to get ammonium levels down, which again makes the brain less foggy. And given that he's gotten an anoxic brain injury, so we think that is really important so that he can wake up. And it's important to make an accurate assessment of the neurological condition. What's also important now going forward is regular blood gases to see whether there's progress from the ventilation side of things. It's important to monitor pathology, it's important to monitor blood results, and so forth. But I want to now open the floor for questions. If there are any questions, please type them into the chat pad, and they can now range from anything you want to know about ICU. I will also give out the phone number. If you are in the US, you can call live on the show now and get your questions answered over the phone now live on the show. You can dial in the US and Canada 415-915-0090. That is again 415-915-0090. If you're in Australia, you can dial 041-094-2230. If you're in Australia, you can dial 041-094-2230. And if you're in the UK, you can dial 0118-324-3018. That is again 0118-324-3018. If you want me to repeat those numbers again, just type it in the chat pad. Otherwise, I want to welcome your questions. In the meantime, I just keep talking more about this particular client. Again, what do I expect with this man going forward? I expect that there will potentially be a prolonged weaning process of the ventilator and the trach. He might be able to get off the ventilator pretty quickly. It really depends on how well his brain is functioning. Will he wake up? It's really important that once he has a trach, if the trach can't be avoided, to get mobilized. He probably would have had the trach a week ago, but with the bleeding, the risk of doing a trach would have been simply too high. That's what I'm predicting over the next few days. What's also important is that he can, be started on nutrition, and that he can absorb nutrition, because he needs to get his strength back, and that again needs to be closely monitored. And what will be important as well is, the longer this goes on, is for everyone to stay positive. And that is easier said than done, because there are often no quick wins in a situation like that. It's slow baby steps forward, but that's unfortunately the nature of ICU. Don't get impatient when this happens. Don't be discouraged. The ICU team might get more impatient than you do, because for them, they need to manage their beds, they need to manage the money, they need to manage their staff. So, as soon as things are not heading as quickly, moving not as quickly as they would like, according to their budget, they get very impatient. They say there won't be any recovery, and, it's still in the quote unquote best interest for your loved one, to die or not to go to a ward, whatever the case may be. So don't let negativity or negative thinking bog you down. Stay positive under any circumstances, because that's really only the option, the only option, to stay positive. That's the thing you can control. You can't control a lot of things in these situations. Yes, we can help you with asking the right questions. We can help you with advocacy, consulting, but staying positive, and we can help you with staying positive, but that's the only thing you can control, is staying positive, asking the right questions. Keep doing that. So then, thanks Anna for your kind words. So then, again, what's next? What's next as well is obviously the liver enzymes need to get under control. The LFTs need to get under control, and hopefully, now he hasn't had any alcohol input over the last few weeks. So hopefully liver enzymes will go down. What's also very important in a situation like this, and I asked the family to pass that on to the ICU team. It's basic nursing care is so important. So what do I mean by that? Basic nursing care, such as regular washes, regular turns from side to side, so that the skin isn't breaking down, right? You can ask a question here, please. I'm looking forward to your question. Please type them into the chat pad. So regular turns are very important. So skin is not breaking down. Mouth care, nose care, simple things like a backwash. Imagine you're lying in bed for weeks on end, and you gotta do washes, regular washes. Little things like that make a huge difference to the well-being. It's like if you're lying in bed all day, you can't eat, can't drink, you're lying in bed for weeks. If someone washes your back, I think that's like having a 5-course meal. It's little things like that you gotta keep asking the ICU for, and especially at the moment with such a massive nursing shortage, I know for a fact that in some ICUs the standards of care have simply dropped. So you're saying it has to do with the TBI your loved one has? Yeah, sure, go ahead and ask the question, right? What's also important in a situation like this is that the PPI prophylaxis is continuing. What do I mean by PPI prophylaxis? PPI prophylaxis means proton pump inhibitor prophylaxis. So what that means is, if you're not inhibiting the proton pump in the stomach, acid will get produced. That leads to stomach ulcers, and that leads to bleeding in the stomach or in the upper GI tract, which is exactly what's happened in this gentleman's situation. So again, the devil is in the detail. Now also, you might be wondering, why does this man have kidney failure, right? A lot of patients in ICU go into temporary kidney failures. Why is that? Why is that? Because they probably had low blood pressure, they were dehydrated and so forth, and that is why patients go into kidney failure, and some of it can only be treated with dialysis, some of it can only be treated with diuretics, right? And NQ says, thanks for your guidance, Patrick, in helping me advocate for my brother. One thing I was told is he's not on kidney failure anymore, but his kidneys are working well now. That's great. That's fantastic. That is really great. So what else? So, well, if they're saying he's no longer in kidney failure, well, that's a good thing. But, we need to verify that, and by looking at numbers and also looking at urine output, we need to do all of that. Okay, what else? So, again, one of the next steps is, for any ICU patient really, is to get mobilized as quickly as possible, because deconditioning in ICU is really happening very quickly. Patients decondition so quickly, they are their muscles weaken very quickly, and it takes sometimes weeks, potentially even months, to recover after a critical illness in ICU. And the sooner that someone can get mobilized, the better it is. And that's for any ICU really. You will find a lot of resistance in ICU for getting patients mobilized, because it's a lot of work, and a lot of ICUs, especially in the US, they say, well, they can get mobilized once they're in LTAC. Well, by then they're deconditioned even more, right? And the risk for complications when someone is deconditioned is just, pretty significant. I think you should request physical therapy pretty quickly, but they probably want to wait until a tracheostomy is done. A lot of ICUs are saying that you can only do physical therapy once a tracheostomy has been done. I disagree there. I do believe that that mobilization can happen as soon as a patient is stable, right? And some ICUs do that, but most ICUs don't. Now, there is another gentleman that has a question. I can't read your name because it's in Cyrillic, I believe, Cyrillic letters, but okay, the question that you're asking is, I'm 19, my girlfriend is 18, we had a motorcycle accident, and she's now about 3 weeks in an induced coma. She breathes 75% from her own, which is a good thing, and generally the only problem is her head. I just need some kind of prognosis. Now, again, I can't decipher your name, but what I will say to you is this is very minimal information for someone that's in ICU. Now, and this is the challenge that most families in ICU face. They don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And what does that have to do with your question? It's got everything to do with your question, because I need so much more information, right? You are giving me probably 3% of the information I need in a situation like that in order to guide you, okay? I would need to know exact ventilation settings. I would need to know medications that she's on. I would need to know a chest x-ray. I would need to know blood results. I would need to know any ultrasounds that have been done, CT scans. So as much as I would like to help you here, I can't, because this is simply, it's probably less than 3% of the information that I need in order to paint a picture for you. So, I do apologize that I can't give you the answer with what you're looking for, but simply that's not enough information, I'm afraid. Okay, what other questions are there that someone has? Please keep typing them into the chat pad, or you can call in live on the show now. I'm curious what else you want to know. Now, just quickly staying on mobilization while I'm waiting for other questions to come in. Especially when it comes to weaning off the ventilator, you can't really wean someone off a ventilator without getting mobilized, right? That's why I'm saying the sooner someone can get mobilized, even before they have a tracheostomy, the sooner the better, right? Because the breathing muscles need to recover, and the breathing muscles can only recover really if someone is getting mobilized and is sitting up, because if you're lying flat all day, or even if you're lying 20 degrees head up, it's not enough to strengthen your breathing muscles, okay? They can only really be strengthened once you're sitting out of bed, you start using your arms, your legs, and only then will things really progress further. And again, this is probably more for our US audience. ICUs will sell you in the US that once you have a tracheostomy, you'll go to LTAC, and then patients will get physical therapy and will get mobilized. Well, my experience is that's not the case. My experience is that's not true. My experience is that in ICU, in LTAC, people do not get mobilized, right? And Q, you're saying, is the tracheostomy safe in your brother's case? I'd say that clinically it's probably necessary. My concern is the heparin infusion at the moment, but that is something they need to control. I think clinically the tracheostomy, as far as I can see, is necessary. Question is about the tracheostomy. That's the question. About the heparin. Right, but hopefully I've seen it before many times where patients are on heparin, and heparin, generally speaking, gets stopped 24 hours before the tracheostomy is done. Tracheostomy gets done. If there's no significant bleeding, low doses of heparin are started again, right? Like with anything, any procedure in ICU unfortunately has side effects, and comes with risks. Comes with benefits. It's like anything in life. Things in life have risks and benefits, but I'd say that in order to speed up to get him off the ventilator, I'd say tracheostomy is necessary unless he wakes up in the next 24 to 48 hours. If he does wake up, things might change, and maybe a tracheostomy can even be avoided. But then again, this is why I'm saying mobilization is so important, because if someone is getting mobilized, their brain is also getting stimulated. So imagine, just picture this for a minute. Imagine you as a healthy person would be confined to bed for the next 3 weeks, for whatever reason. Your brain wouldn't be functioning as normal, would it? If you're lying in bed all day, even though you're perfectly healthy, your brain would get foggy just by you lying in bed. So imagine now you've got a critically ill patient that's been in an induced coma, that had multiple organ failure, that potentially has some brain damage, and they're not being mobilized. Imagine what does that do to their well-being? What does it do to their mental status? What does it do to to their ability to wake up, to process things? The longer you wait, it's not going to help. I've worked in some very good ICU where we started to mobilize patients as quickly as possible. And the sooner you can start doing that, the better the recovery rates, I argue. There's a lady called Carly Dayton. Carly, if you're watching this, I say hello and I welcome your work. Carly is a nurse practitioner in the US. I believe she's in California. Maybe not, but Carly is a nurse practitioner in the US. She works in an ICU where they use no sedation and they mobilize patients early, and they have fantastic results. So shout out to you, Carly, and your work. But that is one ICU. That's the only ICU that I've heard of that. They're getting fantastic results. I don't know how they're doing it. My experience is that when someone needs a breathing tube and an endotracheal tube, that an induced coma is necessary because it's so uncomfortable, so distressing. But they have found ways in that particular ICU to work around that, and they're getting fantastic results. Okay, so you're saying she doesn't have any problem with her blood, heart or lungs, just the head she's gonna fully recover. Again, I doubt that you're saying she's on a ventilator, so she must have some problems with the lungs, right? Again, can she fully recover? I doubt that she doesn't have any issues with blood. Someone in ICU, there's usually always something wrong with the blood, at least temporarily. As much as I would give you an answer, I would need to know more information. Now, NQ, you're saying as a family, what can we do to help him? I think you are already doing everything you can to help him. Like I mentioned to you, recover sooner. It's often baby steps in ICU. And, I think when you look over the last week, NQ, your brother has already taken big steps forward, right? I think he's taking as big steps as he can from what I can see, right? So I think he is already on the right track, considering he's had multiple organ failure in the last few weeks. We're slowly coming out of that. Alex is asking a question. Alex says, would it be safe to say it would be prudent to ask the medical team to start mobilization on the patient of this case? 100%. 100%. You want to gauge their response, right? Because they might actually tell you, no, we won't mobilize him because we think he needs a trach and a Pec, and then we'll ship him to LTAC. You absolutely want to ask that question as early as possible, right? You want to ask that question as early as possible. And you want to see it happening as early as possible, right? What are contraindications to mobilization in ICU? Contraindications are fractures, right? Contraindications are severe bleeding, right? Contraindications for mobilization is hemodynamic instability, such as when patients need multiple inotropes or vasopressors. There are contraindications for mobilizations in ICU, but once there is no more contraindication, and some ICUs might argue, well, mechanical ventilation is a contraindication, and I say, no, it's not. It's not. Unless it's high levels, if someone is on 100% of oxygen and a PEEP of 12, yes, absolutely contraindicated. But I would argue that in this case that we've talked about today, I would argue that mobilization should be considered in the next few days, right? So that's hopefully giving you some insights there. Okay, I usually go for about an hour on these YouTube live streams. I've got a few more minutes left. If there are any other questions, or if someone wants to dial in quickly, has a quick question to ask, but otherwise I will wrap this up in about 5 minutes. I will do another YouTube live stream next week around the same time. Now, you're saying she almost breathes on her own. The ventilator gives her only the 25% of oxygen she needs. Hang on, I just disappeared. She almost breathes on her own. The ventilator gives her only the 25% of oxygen she needs. The rest of breathing, she does it by her own. Okay, so if she does the rest of the breathing by her own, she's probably in a ventilation mode such as CPAP or pressure support. If that is the case, you know, what else needs to happen is, okay, she's breathing by herself. You've got to watch for the tidal volumes. What are the volumes that she's breathing, right? Are they adequate according to her weight? You know, for example, if she's a 60-kilo lady, she should be breathing 400 to 600 mils per breath. You know, if she's only breathing 200 mils per breath, you have a problem. Next, you should be looking at chest x-rays. Are chest x-rays clear? Is there no pneumonia? Right? Is there no consolidation? You should be looking at arterial blood gases. Are oxygen levels good in the blood gas? Are CO2 levels good in the blood gas, right? Next, can your girlfriend cough? Can she clear her own airway? Because if she can't clear her own airway, she will need some sort of airway support, which is often a breathing tube or tracheostomy. Next, how often do they suction her? Are they suctioning her every 10 minutes? Are they suctioning her twice a day? Big difference there. You know, if she doesn't need any secretion, doesn't produce any secretions, and she can clear her own airway, that's another good sign. Last but not least, is she opening her eyes? Is she following commands? So can she squeeze your hands? Can she protect her airway? Can she squeeze her hands? Can she wiggle her toes? Can she wiggle her fingers? Can she poke out her tongue? If that's all a yes, all of those questions that I've just run through, if that's all a yes, then I'd say she has a very good chance of being extubated and getting off the ventilator, right? So I hope that explains things to you. But if you are talking about brain damage, the question is, you know, if she can't obey commands, for example, it might be too risky taking out the breathing tube because she might be at risk of aspiration pneumonia. Right, so look, I'm slowly going to wrap this up. I want to thank you for all your participation and for your interaction with your many questions. So I'll do another live stream next week around the same time. It'll be 10:30 a.m. on a Sunday the 16th of October, Sydney, Melbourne time here in Australia. It'll be 7:30 p.m. Eastern Standard Time in the US, or 4:30 p.m. Pacific time in the US. It is 1:30 a.m. for our UK audience on a Sunday. So look at next week's topic. I'm looking forward to see you all there. And Q's saying he's trying to move his arm today. I'll explain more. Yeah, sure. I'll talk to you a bit later. But that's really good if he's moving his arm. That's fantastic. That's fantastic. It comes down to, is it purposeful movement? But the first step is he's moving it, which is great. You know, the next step then is it going to be purposeful? You know, maybe I should say that too. It's actually, generally speaking, a very good sign if someone is trying to take out their own breathing tube. That's a good sign. Now, I'm not suggesting they should be taking out their own breathing tube because there could be some damage done. But generally speaking, if someone is making efforts to take out their own breathing tube, that's a good sign. That's a very good sign, you know. Now, if you have a loved one in intensive care, go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. If you also have a look at our membership for families in intensive care at intensivecaresupport.org. If you need a medical record review for your loved one while they are in intensive care or after intensive care, please contact us as well. I'd welcome if you give this video a like, a thumbs up. I'd welcome if you subscribe to my YouTube channel here for regular updates for families in intensive care and intensive care at home. I'd welcome if you share this video with your friends and families, click the notification bell, and I want to thank you for coming onto the show, and I will talk to you again next week. Look out for the quick tips that I will be publishing in the next few days. And also want to thank my team working in the background, working tireless, so we can keep serving a growing audience all around the world. Thank you so much, and have a lovely and wonderful weekend. I'll talk to you soon. Take care.